Good afternoon, everyone, and welcome to today's event. We are going to have a very interesting and needed conversation today about kidney health. And without further ado, I want to turn it over to our founder, Dr. Randall Maxey.
Thank you very much, Dr. Robert Neighbor Stevens. Thank you, Dr. Walks, my favorite psychiatrist who provides me with weekly Thorazine that I need. And thank you, our guests, for joining us today. As they say sometimes in the Baptist Church, I'm going to start a series in Ecclesiastics and a number of other books, but I'm going to start with some simple ideas that affect your everyday life. As you may know, we talk about cardiology in the heart, we talk about the brain, we talk about the extremities and nervous system. And I think that we need to understand that all of these systems work together, and each one of them is wonderfully mastered to work together in coordination. So I want to take one subject now, and I tease my cardiology friends to say that in the 1940s, there were only cardiologists. So they took the most intelligent, well-read cardiologists and they made them nephrologists. And everybody thinks that cardiologists deal with hypertension, but it's really nephrologists that deal with hypertension. So we want to talk about kidney disease, and I'll do it with the help of my co-moderators. Simon, can you put the slides up, please? So we want to talk about understanding kidney disease and the Black community. It's especially important in the Black community, as we'll see as we go forward. So we want to talk about kidney health and kidney awareness and how do we protect our kidney function. Let's go to the next slide. So there's a very important function of kidney health. It helps to purify the body. We get rid of a certain number of waste out of the body. The liver similarly gets rid of waste, and the gut gets rid of waste. But a very important part of waste goes through the kidneys, mainly things that are dissolvable and are fluids, and that's what the kidney does. And it's especially important in Black men and Black women. Next slide. So the basic role of the kidney is filtration of waste and excess fluids. And we also know that it regulates electrolytes and acids. Electrolytes are not only the things that are in the fluids that we drink, but it's sodium and potassium, chloride, and also bicarb, and also acids. And the kidney regulates those very finely. So kidney health has a big impact. And because it's very essential for overall health, if your kidneys are unhealthy, your brain is unhealthy, your heart is unhealthy, your liver is unhealthy. So it affects every single thing in the body. It doesn't beat like the heart, but it affects how the heart beats. The risk of chronic kidney disease, called chronic kidney disease, and that's when you have some dysfunction in your kidney for more than 3 months. So they also affects cardiovascular issues. And we know that when you have kidney failure, most people don't die from kidney failure. You die from heart attacks, stroke, and other things, but the kidney failure will kill you, but not at first. Heart will get you first, the brain next. Next slide. So there's a high prevalence of kidney disease, disproportionately so. It's said that more than 40% of kidney failure in the United States is because of Black individuals. So you go to dialysis centers, and we know that white people are the largest number of population in the United States. But in these dialysis units, even an almost lily white community, you'll find that 30 to 40% of the people on those machines are African American. There's a high rate of CKD, hypertension, and diabetes that exists in these communities. So it's very important that we deal with early detection and information and intervention, because once the kidney is damaged, it's very hard to recover that function. A lot of people think you can take this drug, this herb, and reverse kidney function. That is physiologically and physically not possible. Next slide. So there are certain genetic factors, and one is the APOL1 gene. And this gene is there because years ago, for those individuals, especially in West Africa, but in Africa in general, there was a bug, a tsetse fly, and this fly caused sleeping sickness. So in order for the body to adapt to kill the fly, it created this genetic variance, the G1 and G2. And these variants allowed them to kill the fly, not get the sickness, but in the process, it provided for damage of the kidneys. So that's something we need to know about. It's something that you don't find in Europeans, but you do find in people who migrated from West Africa, South Africa, East Africa, into the Caribbean, and into the United States. But even if you go to Nigeria, where you may have people with G1 and G2 genetic variation, sometimes less than 1% of those people actually get kidney disease. Why is that? That's because it may take a second hit. And what is that second hit? It could be HIV disease, hypertension, diabetes, kidney failure from other things that will unleash that possibility of having that kidney failure that happens. Next slide. So there are major risk factors for kidney disease. We know the high blood pressure can cause kidney disease and kidney failure. It damages blood vessels. It reduces blood flow into the kidneys. We know that diabetes itself is a risk factor and can cause kidney damage at the level of the glomeruli and the tubules. A leading cause of kidney damage is diabetic nephropathy, and that scars the kidney, and you can't really reverse it, but there are some things that allow you to slow it down. There are regular monitoring that has to be done so you don't get yourself in trouble. But importantly, what we've said from day one on the Black Health Trust is changes in lifestyle can help save your life. And we know now that there are certain medications that can mitigate kidney damage, not reverse it, but can mitigate it. And we'll talk about those shortly. Next slide. So we know that chronic kidney disease, or CKD, is the disease or lack of function in the kidneys more than 3 months. And we grade them 1 through 5. At number 5, you're going to need dialysis or transplantation. So we want to see that kidney progressively lose function. We want function to be above 90%. When it gets down into 50%, 30%, that's the degree of chronic kidney disease. And we don't want to progress, but if you can manage your high blood pressure, manage your diabetes, it will be much less than usual. We also know that it can be asymptomatic. You may not know anything is going on. It doesn't hurt, doesn't cause shortness of breath or anything, but later you'll find out that it will give you shortness of breath, swelling in ankles. We'll talk about those signs in a few moments. So you want to have routine screening at least once per year. You go to your healthcare provider and have them do blood tests and urine tests, and we'll talk about those. So we need to do these tests and look at something called eGFR, estimated glomerular function test. We also want you to measure the protein that's in your urine. Next slide. So we'll talk just a moment about estimated glomerular function rate, EGFR. And we want your EGFR to be above 90 if possible. And we do know that sometimes pregnant women have an increased amount of EGFR, like 120, 130, maybe even 150 milliliters per minute. But typically we see lower ones, especially as we grow old. So we can say that we want it to be above 90, but at least we want it to be no lower than 60 before we call it chronic renal disease. So we want to have that measured. It's simply a blood test. And recently, we took away the moniker. They measured EGFR for African Americans, and they measured it for Caucasian Americans, and it was different. And it was making insurance rates and lack of transplantation not be available for Blacks. So we removed that function, and now a good lab will not say African American EGFR. We also know that that range should be above 90. Now, albumin is even more concerning. Albumin is a form of protein, and we don't want protein to leak into your urine. And if you have less than 30 milligrams of protein in your urine, you don't have a serious problem. But if it gets to be above 30 milligrams, then there's a problem, and we have some recommendations that we want to make in terms of drugs that can stop that proteinuria so much. Next slide. Lifestyle factors, hydration and diet. So hydration is drinking water and liquids. So you should drink at least 8 to 10 cups of water per day. I tell people to measure maybe 1.5 liters minimum, because you lose almost that much water between urinating and sweating and what we call insensible sweat, insensible loss of water, and also losing water. Every time you breathe, you lose a certain amount of moisture, so you have to replace that. So I tell people to take 1.5 liters minimum per day to replace what you lose. So it's important to keep up with that kidney function. So those 8 cups a day or 1.5 liters per day is very important. And dietary considerations, low sodium diet. We want to eat a lot of fruits and vegetables. That will help your kidneys. We also talked about fatty fish in your diet, especially fish from the North Atlantic, and things like salmon grown in the Atlantic, not the farm-fed things. And we also think shrimp in some cases are good, even though they're high in cholesterol. They make up for it with the other items that are in it. And we also like sardines. Those are good for you. And limiting what you eat in terms of processed foods and lack of eating sugar. We don't want to eat sugars, even though we all love that. Next slide. So there's some medication. I want to spend just a minute on this. There's something called ACE inhibitors and ARBs, which is angiotensin receptor blocking agents. Now, typically I tell Black people don't take ACE inhibitors. And the reason is that the research based on those was not very inclusive of African Americans. So I recommend angiotensin receptor blocking agents. And what they do in a simplistic way is decrease the pressure inside the kidney that damages the glomeruli, because they increase the amount of blood flowing out of the kidney. And that's very important to lower that pressure. So it helps protect the kidney. In addition, it generally takes more than one drug at a time. People say, I'm just taking this one drug. And I'm saying what the literature will support, it takes anywhere from 2 to 4 different drugs, working each of them a little bit below the side effect profile to give you good control of your blood pressure. So if you just want to take one drug, that's not what we recommend. Also want to be careful about taking high doses of diuretics. They can be damaging to your kidneys. And some of them don't work when your kidney function is low, particularly hydrochlorothiazides. There are 2 big types of diuretics. One is a thiazide diuretic, and the other one is loop diuretics, such as Lasix or furosemide. And another talk, we'll talk about how those 2 work and why they work, but you want to monitor that. And also, what we know I think it's on the next slide, Simon. So the renin-angiotensin-aldosterone system, how that affects the kidney. It generates hormones. Angiotensin is the strongest promoter of vasoconstriction and makes high blood pressure high like it is. And so we want to use that RAS drug, whether it be an ACE inhibitor or angiotensin receptor blocking agent, that will help regulate that system. And it is made worse by drugs such as diuretics can make it worse is a problem. So we'll talk about that a little bit later. Let's go to the next slide. There's another drug that the kidney makes. The kidney actually makes its own drugs. And one of them is called erythropoietin, because when the kidney gets smaller, which it does as it lacks function, it stops creating erythropoietin. Erythropoietin is what is needed to keep your red blood cell count, your hemoglobin and your hematocrit high. And it's very important that we give you an injection of that each time you come to dialysis. Erythropoietin is one of the best drugs for that. There are some others now that cause anemia with diabetes. We also want to make sure that anemia doesn't cause a heart attack. So we want to keep your blood cell count up. In the old days, we used to have to give multiple transfusions. And there were problems with transfusion, giving you infection, transfusion, making it more difficult for you to get a transplant. So we want to keep that up by using appropriate erythropoietic drugs in the body. Next slide. So what I didn't talk about was the drugs that you've seen the advertisement before. There's one called Farxiga, there's one called Ozempic, and one called Kerendia. And I'll present slides on that at a different time. But basically, when you have more than 30 grams of protein in your urine, those drugs help decrease that proteinuria. They're called SGL1, SGLT2 drugs, and one is a non-steroidal inhibitor. And those are ones that they're free if you have diabetes. They also are used by many people to lose weight, and they cost thousands of dollars. But if you have diabetes, it's something that can control your diabetes, control your kidney failure. You also decrease the amounts of strokes and heart attacks that you have. So they're very good, and they're paid for. But in terms of signs of kidney damage, we know the early signs are not there. But once you get swelling in your ankles and your legs, that's important. If when you urinate, you get foam in the urine, that means you have protein in the urine. If you have more urinary frequency, if you get up at night to urinate, you shouldn't have to get up at night. But if you get up once, twice, 3 times, some people 5 times a night, not only does it affect your sleep, but it's affecting your balance of fluids. And to say I'm not going to drink water at night, that has its problems too. If you have easy fatigability, shortness of breath, and high blood pressure itself, that could be a sign of kidney disease. And there's a very important thing of monitoring these symptoms and making sure that you get to your healthcare provider to see what's going on. This is mostly as a blood test. For some people, when they come in, I get a renal ultrasound because I know if those kidneys are getting small, that's a problem. If they look dense, it's a problem. But one of the best tests is a nuclear test where we put a radioisotope into your blood and we can see the curve of how it gets excreted. And we can diagnose the exact degree of kidney function that you've lost and how we can affect it. Let's go to the next slide. So it's very important, especially in people of color, to know their family history. And many people have recognized that when they have these family reunions, we need to talk about what happened to grandma, what happened to Aunt Susie, Aunt Barbara, Uncle John, and those people in our family, so we can know if we are at risk and what we should do. We know that many of our families have genetic predispositions to kidney disease, and we need to early on do things to mitigate against that problem. We know that diabetes itself is a problem, high blood pressure itself. So it's very important to be on top of the screening and make sure that you know these things are there so you can act accordingly. Next slide. So regular health screenings are important. We know it's important for early detection. You should educate your family, educate your community. All those things are important, and you should use family reunions for that. And just phone calls, make sure what's going on. Why did Uncle John die? And those things. You want to make sure that we're aware of those on time. Next slide. So it's very important to look at your kidney disease because once it starts, it can be bad. And it says that kidney failure, being on dialysis, can reduce your life extension by as much as 8 years, sometimes more. Even though I've had dialysis patients for more than 30 years, but sometimes it does cut your life short. And we want to make sure that you look at the genetic factors and how to manage those, risk management. We know that you look at the diabetes and hypertension, make sure that you're being screened and know what's happening. You should see your doctor or provider at least once per year. Next slide. So make sure again that you strongly recommend that yourself and your family gets an annual exam, blood results, and take care of that. I also recommend that men especially get PSAs and know what's going on with their prostate. That's an adjunct problem that can cause kidney failure, and we'll talk about that later. I think that's the end of the slide. Let's have some discussion. And are there any questions in the chat, Dr. Neighbor and Dr. Walks?
Dr. Steiner wants to know about the EGFR. How accurate is it?
It's very accurate. Now that they've made the correction go away where they put race as one of the things that's accurate, it's inaccurate in the sense that if you do it in a hospital or research center, you use something inulin, which is a specialized sugar to do it. But this is a urine test, so it's accurate enough to clinically know what's going on. So it's accurate enough, Ken, especially in New Hampshire. So I'm happy to answer any questions or entertain some discussion.
So Dr. Maxey, Dr. Gibson had put a question, and it may be the same as Dr. Steiner's about Black patients and the EGFR. Is there a difference if patients of different backgrounds go into the doctor and they get back an EGFR rating?
No, now that they have removed the distinction between the two,
Okay.
where they have one EGFR for white people and one EFGR for Black people, it is now equal, and it is something that's pretty accurate. We make no distinction between the two groups.
At what age should you start being concerned about potential problems with the kidneys? Especially since it can be kind of silent in the first few years.
Yeah. If you have any of the at-risk diseases, high blood pressure, diabetes, HIV, lupus, any of those diseases, you want to be aware at an early age whenever you're diagnosed with that. But most of us, those things don't express themselves until in their late 20s or 30s. So I suggest everybody get checked at least every 1 to 2 years in their urine. Once you get past 35 to 40, it should be more. If you have hypertension, if you have diabetes, it should be much sooner.
Are there any drugs that you can be taking, not related to kidney disease, that can potentiate kidney problems?
Yes. One of the biggest ones is aspirin, Motrin, ibuprofen, Norco, oxycodone. Almost any medication that's for pain can affect the kidneys and the heart. And in all the medicine you take, you should read the levels read the labels, because a lot of them will expressly tell you that there's a risk for kidney disease, especially if you're overtaking them. Some people say I take 800 milligrams of ibuprofen, and you're supposed to take it 3 times a day with meals. If you're taking it 10 times a day, you're really at risk. If you're taking codeine, even codeine and cough syrup, which almost, I don't think even CVS sells that anymore. All those drugs have propensity to cause kidney disease. There's some antibiotics that cause kidney disease. A lot of times in the hospital, they give you vancomycin, that's nephrotoxic, kidney toxic, gentamicin. All those drugs are kidney toxic, and most of us who used to work in hospitals know that we keep our patients away from those unless it's absolutely necessary. You don't want to kill your kidneys trying to kill a bug. You can help it.
So Dr. Maxey, you've mentioned on Black Health Trust previously about the number of medications for hypertension that would be recommended or should be recommended. And it should not be one medication. It should be multiple medications. And I think today you said as many as 4 different medications may be necessary. If someone is taking one medication and their blood pressure is down within what would be considered a safe range, is that person just different, or should they go to their doctor and say, look, I know my blood pressure is being controlled by this one medication, but I heard that maybe I need more than one medicine?
You're absolutely right. The method that we use to control high blood pressure, and when I talk again on this, I'll try to have some diagrams. But the reason you need more than one, each medicine does a specific thing. For example, one of the best blood pressure lowering drugs is something called a calcium channel blocker, and it dilates blood vessels all over the body. But in many cases, it still leaves the pressure in the kidney still high. So even though it may control your blood pressure, the pressure in the kidney may be high. So if you add something like an ACE inhibitor, or better yet, an angiotensin receptor blocking agent, it releases the pressure to back into the kidney. That protects your kidney. So that's 2 drugs that work in concert. So that's better. And we now know that there are drugs such as the Farxiga and the Corindia that can lower the amount of problems inside the glomerulus in terms of inflammatory reaction that makes it better. So we know that you need several drugs to adequately protect those kidneys and your heart and your brain. And just one, your blood pressure alone being lowered, doesn't necessarily by itself lower your risk. Even though we know that if your pressure is above 120/80, you're still 60 to 70% more likely to have a stroke, heart attack, or other event from that pressure being high.
So Dr. Maxey, before you get too far away from that, there are a couple of comments in the chat, but I want to make sure that I'm clear on this. So I go to my doctor. My doctor tells me that my blood pressure is high and prescribes medication. I take the medication and I come back to the doctor, and my blood pressure is now within a normal or a safe range. How do I get the doctor to give me something else, or how do I get the doctor to check that back pressure you talked about? Because I don't know that a lot of people, and here on Black Health Trust, we don't tell folks what to do. We tell them to go to your doctor and talk to your doctor about this or about that. So how do I talk to my doctor about this concern that I'm someone whose pressure is now within a normal limit, but I'm concerned about my kidneys?
So if you can get your doctor, a lot of family doctors and even internal medicine doctors are not, especially if they're not of color, are not as familiar with the things I'm telling you. So you want to find a high blood pressure specialist. You want to find a nephrologist, you want to find a cardiologist who's more likely to know the details of how to treat hypertension. I have a very good friend who takes red wine vinegar and his blood pressure controlled. But his kidneys are still very much at risk. His brain is still at risk. So it's not just the blood pressure itself that leads to the risk, but the way your blood pressure affects your internal organs. So the best you can do is ask your doctor to get a second opinion for you. You still love him, but you want to get a second opinion on how to address your blood pressure. Does that address your question?
Yes, Dr. Maxey. It just lets me know that we have a lot more work to do than just go to the doctor and take the advice the doctor gives us. It sounds like we have to be very active, getting information from places like Black Health Trust, and then being able to have a doctor who will talk with us and answer questions. Because it's not as simple as, we always talk about, well, know your numbers, know what your blood pressure is, know what your blood sugar is, and it's not quite that simple as what I'm hearing from you.
Yeah, a lot of men that I talk to, they say, I don't know what medicine I'm taking. I don't know what I'm taking. I say, well, what kind of oil do you put in your car? Oh, DW40. What kind of tire pressure you use? Oh, 36 PSI. They know all the details. I said, we need to know the same level of details about your life and your body.
Amen.
So Dr. Walks, maybe you can handle this. When I say handle, even understand, I don't really understand the question from Zoom user.
Okay.
Let them answer the question.
The reason you don't understand the question is because Zoom user is a psychiatrist, and I'm not sure that we ask questions in a way that non-psychiatrists can understand. Can we unmute Dr. Lawson and let him ask his question? He's trying to be incognito over there and put complicated questions in the chat. Go ahead, Dr. Lawson.
Yeah, can you hear me okay?
Yes, sir.
Yeah, the issue is that right now, there's a lot of evidence that shows that lithium is probably not as neurotoxic as we used to have. Despite that, a lot of people don't like to use it. Yet at the same time, bipolar disorder is grossly under-recognized in African Americans, and when it is recognized, folks are undertreated. Many of the agents they're avoiding lithium, they end up using these other agents, which frankly aren't very as effective. So I want to hear your thoughts about that, especially also since the usual blood levels for lithium is not as applicable for African Americans as is for other groups.
So the gist of your question is, what is the effect of lithium on the kidney?
Yes. Well, yeah, and again, the issue is that a lot of folks avoid it, and yet, and also underdiagnosed bipolar disorder because of it. We have evidence that the rates of bipolar disorder can be as much as 5% of the population, especially bipolar 2. Folks end up in jail. They end up all kinds of adverse effects from undertreated bipolar disorder. And yet we have a treatment that's at least we've seen especially useful for folks who have disorders such as bipolar 2.
So let me ask this question by asking you a question.
Yeah.
So are you finding that people decrease the amount of lithium because of concern about renal effects?
They don't give it to folks. They don't even ask about it. There are a lot of physicians simply don't offer it. And try to manage it with antipsychotics or just simply ignore it.
So offline, I'm going to call you and maybe we'll go through a thought process about it. I don't want to jump into something I don't know much about with the lithium.
So
what I wanted to say to Dr. Lawson, with all due respect to your knowledge, I don't think fear of lithium is the reason bipolar is underdiagnosed in the African American population. I'm just saying.
Yeah, probably. The other issue, of course, but I'm saying that when it is diagnosed, I've seen people say, "Oh, this person have bipolar disorder." Well, we just give them a diagnosed bipolar disorder. We have to treat them, and we don't want to give them antipsychotics, and we don't want to go through the trouble of trying to manage lithium. So why don't we just not give them anything? And this is
So-
especially true in terms of people in correctional system.
So let me jump into this question also, Dr. Lawson, because it's actually a really important question with respect to lithium, bipolar disorder, and kidney disorders or chronic kidney disease. As I'm sure you know, Dr. Maxey, one of the challenges with lithium has to do with water regulation and people drinking appropriate amounts of water. I'll just put it that way. And then folks have to get the lithium levels checked. And so I think this goes back to one of the things that Dr. Neighbor Stevens was just alluding to. There are a lot of reasons why people who are blessed with color don't get the level of treatment that is appropriate for the differences in our varied populations, because it may be a lot of work. It may be more work. Multiple medications, monitoring 2 or 3 different medications for blood pressure, that's more work. Looking at a medication that requires you to periodically, once or twice a year, draw blood levels, that's more work. And so I think that it goes back to us really needing to make sure that we are advocating for ourselves, that we are connecting with doctors and other practitioners who are going to take the time to look at the unique needs of individuals within our populations. Because every time we talk about things we need to look at, different organ systems, different diseases, they require more than just a once a year visit and the doctor writes you a prescription. There's more to it than that. So yeah, there's a whole nother Black Health Trust session in why things are underdiagnosed and undertreated. And there have been volumes of books and scientific articles done about unequal treatment in communities blessed with color. So yeah.
Let me throw out one other point. We found that 10% of people in primary care clinics, and this has been replicated multiple times, have bipolar disorder. And those who are in primary care rarely get get treated with lithium and other agents. And I'm just wondering, primary care doctors given any kind of awareness or training in terms of recognizing that this may be a reason why your patient can't get along with his wife, keeps running deficits in his bank account, and keeps ending up in jail.
Mm-hmm.
Well, Dr. Lawson, again, you're around academics, and all you got to do is look at the curriculum and you'll have the answer to your question.
Unfortunately, yes.
So there is something, Dr. Lawson, that I'd like your comment on. We know that as your kidney function goes less than 60 cc's a minute, that you begin to retain a lot of heavy metals and retain such things as phosphorus, and it goes up, affects your parathyroid hormone.
Mm-hmm.
How much mental and brain effect is the increasing amount of these items on your psychic and mental health?
That's an excellent question. And the reason it's an excellent question is because we now know that some disorders, such as major depression, is overrepresented in people who have chronic renal disease. In fact, we did a study showing that a substantial percentage of the people who were getting renal dialysis were depressed. And we found, when we look at the life circumstances, factors that's involved, find that the amount of depression is not related to life adventures. It is not just related to having chronic renal disease. So there's something about having chronic renal disease that seems to increase the risk for major depression. I'm not talking about being sad every once in a while. I'm talking about the full-blown problem of major depression, disturbance in appetite, disturbance in sleep, difficult feelings of hopelessness, helplessness, and sometimes persistent suicidal thoughts. So unfortunately, that's been well documented. I think what you're providing is somewhere where we need to look at this to try to understand it. But the evidence is strong. Having renal disease, chronic renal disease, is associated with high risk of major depression, and it's not just because you're sick, or because you have the disease itself.
So let's go a bit further and talk about the effects of the kidney on even the gut and levels of things like serotonin and other hormones that act in the body. We also acts on the axis with the catecholamines and affects the amount of dopamine. So it can
Yes.
have
Yes.
affect almost every area of the body that affects your mental status, your physical status as well. Everyone is altered. So we have a salad.
Absolutely. And then some people call the gut as the second brain. You say the same thing about the kidney. And if you go in and look very closely and look at these neurotransmitters, you find that there is a complex interrelationship that's associated with mood states. It's understudied, needs to be studied more, and I think it has a special complex reaction in terms of African Americans because we are also exposed to chronic stress, which is also affecting these hormones as well. So you have a combination of being exposed to chronic stress, combination of chronic renal disease, combination, all these together will lead to what we call a kind of depression and perhaps even other mood disorders, or even frank psychosis that tends to be refractory to the usual medication treatments that we have. And we already know that talk therapy or psych therapy by itself is often highly ineffectual.
The other thing that happens is that most people with kidney disease, especially chronic kidney failure and end-stage renal failure, don't exercise as much. And that decreases your level of endorphins, which is going to affect your mental status as well. So we know that all these things are definitely interrelated. And maybe over the next few months, we can unravel some of that, Dr. Lawson.
Yeah, let me just add one other point, and that is how often do you screen for suicidal thoughts in a usual clinic or places where folks get getting dialysis? And what we know is that the suicide rate among these folks is higher than the general population. And again, I think the evidence is strong that it's not simply a result of people being in distress or bad things happening to them. I think it's also the nature of the illness itself and some of the chemical changes that's producing in the brain.
Yeah, in every dialysis center, we have at least 2 licensed social workers, and they deal with the mental health of the patients because we know there's increased suicidal ideation in that group of people. But they also have the other attendant problems of social adjustment there too. So we have, like in our Puerto Rico operation, we have 18 dialysis centers. We have over 50 licensed social workers just to deal with those 18 centers.
And related to that is the issue of making sure that people come in regular and get the kind of treatment that you've identified, coming in and actually making sure that they maintain the dialysis. Why do they suddenly start staying home? Why are they indifferent to it? And as you say, why do some of the folks don't even want to know about the blood chemistry in their laboratory? Part of it has to do with their mood state, which they may not want to refer to themselves. And a lot of folks do not call it depression, but it's one way of expressing that depression. That is, they become apathetic to their physical health and following through in terms of treatment and adherence to a treatment protocol.
Now, another thing that happens on that, we know that the kidneys normally work something like 164 hours a week, but dialysis lasts at most 12 hours to 16 hours per week. So how much buildup of toxins, neurotoxins, is there just by 3 days of 4-hour treatments? You're getting a lot of stuff built up, and that will affect your mental status and body. as well. So I think we're
Absolutely.
close to the top of the hour here.
We're not quite there yet. Dr. Gibson has asked, I think, a very important question because of its common occurrence. He asked, what is the impact of alcohol consumption on kidney health? Well, he didn't quite call it kidney health, but on kidney health.
The alcohol is not a direct relator to kidney disease. Alcohol is primarily a toxin that affects the liver and is cleared by the PGY system of metabolism in the liver. What it does in terms of the kidney, it has an effect on antidiuretic hormone, and you may pee more through the kidney, but it is not directly a nephrotoxin as much as a hepatic toxin.
And let me just add, in these days where we have a lot of folks with dementia and other sorts of memory problems, alcohol is not a good thing for someone to take. It's not only toxic to the liver, it doesn't help your brain work well either. So I'll just add that.
Okay. Well, I think we're getting close to the top of the hour. I'm going to have our adjunct speaker have last words, and then our co-moderators, Dr. Lawson, you want to have the first final word? And I'm messing with you.
Dr. Lawson, you are back on mute.
Yeah. Final word is that that mental disorders are a result not only of what's happening in your brain directly, but also you have to look at your total body. Part of maintaining good mental health, preventing dementia, is to make sure that you take care of your entire body throughout much of your life, and the best outcomes are when you are conscientious about keeping track. As you said, the excellent analogy, it's like you maintain your car and want to get some good mileage, and make sure when you trade that car in that you can get some good gain for it. Same thing with your body. Only difference is we can't trade our bodies in. And what we got is what we got, and we need to make sure that we take care of it throughout. And a lot of it is just simple, just like a car, keeping regular checkups. Same thing with your body. Regular checkups on a regular basis, and have somebody interpret them for ourselves.
And Dr. Lawson, Dr. Walk said he's upset with you because you haven't been inviting me to the barbecue. Dr. Walk, final words.
My thoughts for today, Dr. Maxey. As I listen to Black Health Trust and participate, I continue to be more and more concerned about the opportunities that we have to do better, both on the common sense, I'm going to the doctor regular side, and on the doctors who are working in our communities, keeping up with the changes. Dr. Lawson talked about things that are different than they used to be. Dr. Maxey, you talked about many things that are different than they used to be. And I'm glad you said this is going to be a series that you'll do, because these kinds of updates can be very useful as we go in to our regular doctors for our regular checkups. We can ask about multiple medications for high blood pressure. We can ask about whether our blood pressure is really checking all of the different areas of blood pressure, or whatever words we use. We can try to explain to the doctor that we're concerned about our kidney health, not just our high blood pressure and if we're going to have a stroke. So I think that the opportunity is there for us to continue to share this information, and for us to receive information, both doctors and lay people alike, and take it with us as we go for our own health care.
Thank you, Dr. Walsh. Dr. Nabors-Stevens.
My closing thoughts today are not going to be directed to any of the healthcare professionals that are on the line specifically. I really am addressing these to everybody on the call. And that is, as Dr. Walks just highlighted, we've had several in just this call, but we've had other calls where it was true as well. Several examples of where what has previously been thought as correct has been proven to not be correct or not to be as useful as we thought. An alternative should be concerned, and just examples of new information about mechanisms with the APO1 gene and hypertension. And there are tons of others, which leads me to something that I think all of us need to be thinking about and asking questions about. As we advance, because it's already started, as we advance in this frontier of AI and the development of the algorithms that are being created specifically in the healthcare space, I have not just recently, I have from the onset of all of this, have been very concerned about the content and the accuracy of the information that's being used. You know, we used to say about computers, garbage in, garbage out. And this is really a situation where I'm worried about garbage in, garbage out. So I want our audience, which is a fairly sophisticated audience, to be aware, read what you can find on AI and healthcare and how it's being used, and start asking some questions, because I am not comfortable with what answers I have gotten recently about what safeguards there are as we go forward with AI in healthcare.
Thank you, Dr. Robert Davidson. And as my last word, I heard a sermon by the great civil rights worker named, what's the guy's name on NBC, the black guy? Al Sharpton. And I was very impressed with what he said, why we need to vote. Because we know that even though we have a democracy, that early on, this democracy did not include people like us. You do not have the right to vote. You do not have the right to an opinion or a right that the white man needed to respect. You do not have the right to really protest. You did not have the right to think. And we didn't need to know that this election coming up, we're not telling you who to vote for, but you need to exercise the right while you still have it and to keep it. And vote for people who are likely to support you, your life, and your health, and your ability to protect yourself. And we know that certain other groups have made it a part of the US government that if you go against a certain Middle Eastern country or Middle Eastern thought, that you are anti-Semitic. We need to make sure that we protect people from being racist and anti-Black or anti-people of color. So use your vote very wisely. There's no reason not to vote, no reason to sit out, no reason to vote for a third-party candidate who can't win. The die is cast. And I suggest that you don't vote for a particular party, but I believe since we know that intelligence is carried by the X chromosome and the DNA, that you consider voting for a female. Thank you very much. Have a great day. Thank you, Simon. Thank you, Dr. Walks, Dr. Neighbor-Stevens, and Dr. Lawson. Have a great, great day.
Good day, everyone.
Bye.